It is my pleasure to introduce Dr. Denise Adams next. She's a pediatric hematologist-oncologist that has been taking care of patients with vascular anomalies for almost 30 years. She recently moved to the Children's Hospital of Philadelphia to lead the complex vascular anomalies program, and we are so thrilled to have her here. Prior to this, she was at the Boston Children's Hospital, where she co-led their Vascular Anomalies Center and served as an associate professor of pediatrics at the Harvard Medical School. And before that, she served as the medical director of the Hemangioma and Vascular Malformation Center at Cincinnati Children's Hospital, where she spent 13 years and led the Hematology Oncology Fellowship Program. She's actively engaged in clinical and translational research on complex vascular anomalies and specializes in new drug development for this group of rare diseases. She also led the pivotal work in the development of mTOR inhibition for the treatment of complex vascular anomalies. We're so excited to have you, Dr. Adams.
Thank you very much. That was a very gracious introduction. I usually say that I've been doing this for 25 years, so but I guess it has been 30 years. So I'm just getting old. But I am a pediatric oncologist, and I got into studying vascular anomalies when I was a fellow. And the reason why was because I had a clinic the same day as a dermatologist had a clinic. And the dermatologist would send me all of his vascular anomaly patients that needed medicine. And I looked at these patients and they all looked different, and I wasn't really sure what I was doing. So I went to the library because there was no internet at the time. And I became very good friends with the librarian. I was at Duke at the time. And then I went to Boston to learn about vascular anomalies because I really became passionate about taking care of these patients because they had no treatment options besides surgery or intervention. I also became passionate about P10 patients because about 30 to 50% of P10 patients can have vascular anomalies. And vascular anomalies are usually seen very early on in life. And vascular anomalies can have a very significant morbidity, and sometimes they can definitely be life-threatening. And so that was where my passion for P10 patients and vascular anomalies came from. So I do want to warn you that we're going to talk about the background. I'm going to talk to you a little bit about the classification. And we did this a couple of years ago. And unfortunately, the best way to do this is with pictures, because pictures are going to show you what these patients are going through that have vascular anomalies. So I'm sorry, I'm glad we're doing it before lunch because some of these pictures are really quite significant. So we'll talk about the classification in P10 patients. We'll talk about some improvement that we're doing with that classification. And then we'll talk about treatment options. It's been wonderful that everyone is talking about this PIK3CA or this mTOR pathway, because that is where we moved with vascular anomalies. And we have several opportunities that we could do with patients with P10. So I didn't put a disclosure, but I am a consultant for Novartis. I've been working with them on the alpelisib drug, and also I'm a consultant for another company called Venthura and another company called Nobias. So these are ways that we can get drugs to help our patients. So when we think about vascular anomalies, so again, we're talking just about vascular anomalies. We divide them into tumors and we divide them into malformations. And when we think about, there was a very, very simple classification system when I started that was simple like that. A tumor is something that grows, and a malformation is something that we felt did not grow, but it grew when the patients grew. But that is not the case. So we have a group called the International Society for the Study of Vascular Anomalies, and this is a group made up of medical doctors, surgeons, radiologists, a whole spectrum of different subspecialties, and we get together once a year now, and we have revised this classification. So that simple classification, which was 1 page, is now about 20 pages. And it's linked to more specific disorders. And we also have genomic information that is mostly not germline, but mostly somatic changes. So changes in the body genes that cause vascular anomalies. So this is broken down now into tumors, and the tumors are better defined. We do have malignant tumors, and we also have benign tumors. And then it's broken down into malformations where you have simple, straightforward malformations, you have combined malformations, and you have other disorders that don't fit into one category. So when we talk about tumors, the most common tumor that we take care of, and it is a tumor, but it's a benign tumor, is a hemangioma. And I think we talk about hemangiomas in P10 patients, but P10 patients do not have an increased risk for hemangiomas. So I think P10 patients can have these things, and I'm going to show you a picture. They can have capillary malformations. And in the olden days, or if you're at a center that doesn't really have like clinical knowledge about vascular anomalies, capillary malformations can be called hemangiomas. So I do not think that P10 patients have an increased risk. This is a very common benign tumor of infancy. It usually shows up after birth, and about 20% of infants can have this. And they can be small, they can be large, they can be diffuse, and these are all pictures of what we call the heterogeneity. So this is the same disorder. This looks the same under the microscope, but this is what we call a superficial hemangioma. This is a superficial and deep hemangioma. And this looks the same under the microscope, but this is a diffuse infantile hemangioma of the liver. So they look different, and you do not need to worry about these in P10 patients. They can have them, but they can be just because it's common. So these are other horrible malignant, sort of intermediate malignant tumors. And this is really why I got interested in vascular anomalies. This is something called a KHE lesion that usually happens in the neonatal period. And this has not been shown to have an increased incident in P10 patients. But there are other malignant tumors such as angiosarcomas that we don't typically feel are related to P10. But Suzanne and I actually have a patient that has had an angiosarcoma. And that's why it's really important, dermatology is all part of the specialists that are involved in your care. And now if people have vascular anomalies, a vascular anomalist is important in that care as well. And it's important for us to assess any changes and any lesions that are there. So when we talk about vascular malformations, remember these are not tumors. These are usually present at birth. You might not realize that you have them, but it's really unusual for these to present in the adult period, though they can. They usually present in the newborn period and also in the school age period and all in that childhood age group. So this is an infant that was born with a capillary malformation. So I think when these are associated with other lesions, sometimes they're called hemangiomas, but they're not. They have a very distinct look to them. They don't go away like hemangiomas go away. This is another picture of a capillary malformation that can get light and can be treated with laser. These are pictures of lymphatic malformations. So these are abnormal lymphatics, and they can be cystic with large cysts, or they can have very small cysts. And then this is a venous malformation. So you see that it's a bit bluer on the lip. So it's made of veins versus made of lymphatic vessels. And this is another picture of mostly a lymphatic, but because lymphatics are derived from veins, it can look like it has a venous component to it. And this is another picture of a more diffuse capillary malformation. So when we think of these lesions, they're broken down into whether it's a slow flow malformation. And when I say malformation, it means that the vessel has not grown correctly. It's more immature. So when I explain things to my patients, I always draw a lot of pictures. And so a vessel usually has a wall to it that's very precise. It has a layer of muscle, and veins have less muscle than arteries, and lymphatics have less muscle than veins. And then all vessels have these cells called endothelial cells that line them. But usually our vessels are very precise. So when you have a malformation, that vessel has been formed abnormally. And so the wall might be a little too lax. There might be abnormal smooth muscle, the cells might line up and have gaps in between them, so they can form these cystic structures if it's a lymphatic malformation. They can cause issues if it's a venous malformation, because sometimes you can get inflammation to those veins. So they're not like a normal vessel, and that's why the word malformation. I'm not sure I like these terms that were given, but that's why they call it that. So vascular issues are also can have combined lesions. So you can have a capillary malformation with a lymphatic malformation with a venous malformation. You can have a venous malformation with a lymphatic malformation. And so these are the combinations. And now we know that there are some genes, most of them somatic, so body genes, not genes that you can pass on to your children. So remember when we were talking about the thyroid cancer, and there are some somatic changes in a thyroid cancer that can be P10, but it's not inherited. Well, these somatic changes, most of them that are in vascular anomalies, so we're not talking about P10 now, we're talking about just patients with vascular anomalies, are actually changes in those body genes only in the areas where you have a vascular anomaly. So some of these, this is a combined lesion, and you see that this is a capillary lesion on the outside. You see it has these little blue marks. So in the in old times, they were called hemangiomas, but this is actually lymphatic blebs from that leakiness of the lymphatics. So it makes it look more blue and crusty. This leg has some overgrowth, and the overgrowth is because of a lymphatic malformation. So this is a capillary lymphatic venous malformation. And another word for this is Klippel-Trenaunay syndrome. This is a patient that has congenital Lipomodus overgrowth with vascular anomalies and skeletal issues. So this is a diagnosis that we call CLOVES. So CLOVES is C-L-O-V-E-S. So congenital Lipomodus overgrowth with vascular anomalies, epidermal nevi, and skeletal abnormalities. So this patient you see has a capillary lesion. You see that there is a lymphatic lesion underneath this, but there's also some Lipomodus overgrowth. This patient also had Lipomodus overgrowth over the back. This patient, though, has some vessels in the spine, so this patient also had an AVM in the spine. And this is also another patient that has this overgrowth that's really combined. It's a lymphatic, and also there's a venous issue with this as well. And this is a child that has CLOVES too. So again, notice the heterogeneity. So these are caused by the same somatic mutation, but they look very different, and they have different types of vascular malformations. So it's wonderful that we have new drugs, and I'm going to be talking about some of them, but the drugs, the effectiveness of the drugs might be different depending on what we see. And what we see is called the phenotype. So for example, what I see with this is Lipomodus overgrowth. What I see with this is Lipomodus overgrowth, but also a capillary lymphatic venous malformation. So these patients might respond differently to the different drugs. So what do we know about vascular anomalies in PHTS? So vascular anomalies from older studies occur in about 30 to 50% of patients with P10. There are several papers that are written, but really not a lot of papers that are written. It needs to be much more than this. The first paper that really brought vascular anomalies together was written by the Boston group. The first author was a geneticist, and the other authors were vascular anomalists. And this was looking at the spectrum of vascular anomalies in patients with P10 mutations. And what they found was that the majority of these patients had high flow lesions. But this is interesting because now with our reviewing these patients, these all were not AVMs, and I'm going to talk about that a little bit because it's really important. Again, going back to that phenotype, we need to know what the vascular anomaly is because then we know how best to treat that vascular anomaly, even in a P10 patient. Okay. So 57% had multiple areas of involvement, and that's really important because the gestalt from this was that overall patients with P10 appeared to have more complicated vascular anomalies than other patients. Vascular anomalies are rare. The common ones are simpler than the ones that are more significant, but patients with P10 seem to have the more significant vascular anomalies. There was then a paper that came out from Cincinnati, and they basically looked at the impact of vascular anomalies on the P10 phenotype. So were patients with vascular anomalies, did they have a higher risk of having cancer at an earlier age? Or what were their vascular anomalies like? And so what they found was that they had a more bulky phenotype. A bulky phenotype means that they have more overgrowth and it's more of a significant vascular anomaly, but they did not have any increased oncologic risk. And those were about all the papers that we had looking at vascular anomalies in P10 patients. And so you saw the vascular anomalies without P10. So these are some examples of vascular anomaly in patients with P10. And so you can see that, yes, people with P10 have to worry about their thyroid and worry about breast cancer. But for these patients and some of them, this was very significant for their life. So this is a patient who's doing quite well now because he's on medicine, but this patient had a combination of vascular anomalies. So Lipomodus overgrowth throughout the retroperitoneum with lymphatic malformations. This patient also has multiple AVMs, and this patient has had multiple surgical procedures, interventional procedures, and is also presently on an mTOR inhibitor. This is a patient as well that had significant overgrowth, which was mostly lymphatic. Also had some lymphatic blebs that bled. This is a patient that also has disease in the retroperitoneum, so you can have renal issues with this. And then you see the right side of the leg and how significant this must be for skeletal issues, for functionality. This patient has a hamartoma, but it is a high flow hamartoma. So this patient was diagnosed with having a tumor, they thought was a tumor, and it wound up being a high flow hamartomatous lesion that P10 patients have. And this was the same thing, this patient had a hamartoma as well. So this is just an example of the high flow lesions that you can have with P10 patients. So when you have someone that has an arterial component to their vascular anomalies, it is an abnormal flow that goes into an area. You have dilated veins that occur afterwards. And basically, it is significant because you can have destruction of things around that area. You can also have heart failure because this AVM has a lot of flow going into it, and your heart is a muscle and it has to work harder to get the blood to where it needs to be. So some of these things are very, very significant. So I had a undergraduate student when I was in Boston that had an interest in P10. And what she did in 2016 is she took our patients from the registry that we had. So this is a broad vascular anomaly registry at Boston. And she looked to see if maybe with the new classification, if there truly wasn't over 50% of people who had high flow lesions, maybe they were other lesions and we could classify them a little bit better. So she went through, she did a retrospective analysis. Some of these things you're going to know. We looked at 26 males and 24 females. Shows you the percent of the patient. The average age was about 21, 22. The average age of the first symptom was 5.8. These were some of the symptoms that the patients had. But then when she broke them down into our radiologists looking at the findings, what we found was we could break these lesions down into fast flow hamartomas. So hamartomas are just like extra fibrous tissue that are there. But these lesions can be associated with very high flow vessels. So if you look at them radiologically, they can look like a vascular tumor. Sometimes they also are misdiagnosed as an AVM, but important to know that. Then we felt that there was another group that were non-fast flow hamartomas. We did have some pure AVMs. So an AVM purely is when an artery comes into a vein, you have a capillary bed that helps buffer that flow. And in an AVM, that capillary bed is gone. So you have a nidus of all this entangled high flow arteries. And because of the high flow arteries, you have a lot of draining veins that happen, and it can be very, very significant. So most of these patients had intervention. So you see the percentage of medical intervention. Most of it was with mTOR, but back in the day, we were trying to use other anti-angiogenic medicine, interventional radiologic procedures they had, and also surgical procedures. And so basically the conclusions were that P10 patients were underdiagnosed, right? They should be diagnosed way before we see a vascular anomaly on them. That hamartomatous lesions were often missed, and some of the lesions progressed pretty significantly. Most of those were with the high flow lesions, and they appeared to be more complicated than other vascular anomalies we saw without P10. And that pain and functionality were the biggest issues that these patients had. But there were also a lot of vascular anomalies that were confused with P10. So there's something called fibroadipose vascular anomaly. And it looks like a hamartomatous fibrous lesion. And we found a lot of patients who were diagnosed with that had P10. And so very cognizant, I know the macrocephaly and the large head, but to us, when we walk into a room and we see that with a vascular anomaly patient, we automatically think P10. And we have to, because a lot of these kids were not diagnosed because people weren't thinking about that. So what we're doing now, and this is a bigger project, and this is an international project, is we really need to have a better classification system. This is different than the classification system for ISSVA. ISSVA is helping us, but we have to have a better classification system. Because if we're going to be introducing new drugs, right, we talked about the diversity, the heterogeneity of the phenotype, we really need to know what we're taking care of and what the phenotype is. So we have a team of experts in radiology, in pathology, and also in kind of outcome measures. We got together very quickly and we sort of broke it down into, this is our schema that we're looking at. So this is what we think is the classification. Whether this is going to pan out to be the classification at the end, we don't know. And we have leaders of the group, and then we have leaders of the subgroup. And I don't know if you can see this, but the beauty of this is that this is an international study. So we have a group of international registry and outcome measure experts. We have imaging and interventional experts. We have pathology experts. And we also are really fortunate to have a support team. And the P10 Research Foundation gave us some funding to start this. So our aims are to have the pathology people and the radiology people independently look at all of their images and all of the pathology and try to stratify this into a better classification system. Now, this is a heroic effort, because if you're thinking about radiology, I'm not sure how many radiologic imaging studies that your children have had, but there are hundreds of studies that are out there. And our radiologists are, it's blinded. They have sort of a data set that they're working on that we have developed over the past 6 months, and they're trying to classify radiologically what this vascular anomaly is. In the meantime, the pathologists are looking at, we don't have as many biopsies, but the pathologists are looking at all of the biopsies to see what is truly a hamartoma, what is a hamartoma, what is truly a high flow lesion, what are the combined lesions, so we truly have a better sense. And when that's all done, they will bring that all together and analyze it. And our hope is to have a classification system at the end of this, because our goal is that we can use this for inclusion criteria in our studies. And we can also, response is different. Response isn't just, this is getting smaller, because the lesions might just be stable, but pain might be improved, functionality might be improved, exactly what Dr. Sid was saying. So this just goes through that. These are some more pictures just for you to see what these things look like. So this was called an AVM. This is really not an AVM. This is a vascular hamartoma. You see the veins here and all of this tissue that's here. This is a patient that truly has a high flow lesion. And so you see the nidus. Remember, I was talking about that nidus of the AVM and all of the vessels that are around it. And this is what it looks like sort of on MRI imaging. This is a patient that also has a high flow hamartoma. This was diagnosed as a tumor initially. And this is another patient that has a high flow lesion. And this was treated with sclerotherapy and also embolization. So you see the coils. This was causing heart failure. So we had to block those vessels that were abnormal. This is what I was talking about, what probably in the past was called a hemangioma. So this is not a hemangioma. This is a lymphatic malformation where you have lymphatic blebs and they bleed and they're very significant. You can put topical therapy on that. If this patient was treated with topical sirolimus. And the treatment typically for vascular anomalies is surgical removal if we can. Sometimes you can use laser therapy and interventional radiology. You can use sclerotherapy. Sclerotherapy means injecting a medicine, which we call a sclerosant, which is used to destroy the tissue that's in that vascular anomaly. Embolization is used to block the flow. So embolization is used for a lot of arterial venous malformations. And we're using more and more cryotherapy, which is freezing of, we'll call them tumors, so mostly for the hamartomas, but we also use it for the vascular anomalies. So quickly, let's talk a little bit about what did we have for medicine? What did I have for medicine as a vascular anomalist? So when I was an oncologist, I had studies. I had the children's oncology group. I had genomics. When I got into this world of vascular anomalies, there was nothing. People were using different medicine, and I think I showed you this slide a couple years ago, but I call it the chicken soup of vascular management. Anything that was anti-angiogenic was used to treat every different kind of vascular anomaly. And remember, I talked about the heterogeneity. One medicine might not work the same depending on what the diagnosis is, what the phenotype looks like. So I was incredibly frustrated and really felt that sort of why I dedicated my life to this. We learned from this because we used interferon for a lot of patients that were younger than 12 months of age. And with interferon is an anti-angiogenic agent, and it works well for some of our tumors and for other vascular things that I take care of. But in infants, it can cause spastic diplegia. So we learned that. We also learned that excessive use of steroids, which is also an anti-angiogenic therapy, had some side effects as well. And then what happened was one patient came to see me when I was in that clinic and changed the way we thought about vascular anomalies, because this was a patient with one of those tumors called a caposiform hemangioendothelioma. And this was a patient when I was in Cincinnati where we actually had a standard of practice. So this diagnosis came in, that this is what you did. We had no information, not a lot of information about genomics at the time. So this was in like 2007. So we did know that P10, we knew that P10 patients had an increased risk for vascular anomalies. And we also knew that there was a germline mutation in something called TI2 that caused venous malformations. And when we sat down when this patient came in and nothing was working for this patient in our typical regimen. And we sat down and we said, what pathway? I'm an oncologist, just like the oncology talk that you heard before. I think about pathways. What pathway could be involved in this? Well, we came up with the PIK3CA pathway. It really should be involved in this. P10 comes into this pathway, TI2 comes into this pathway. And the only medicine that we had at the time to use was mTOR inhibition. And so I was thinking that someone would say, and I think Sid mentioned it, why use everolimus? Why not use sirolimus or vice versa? So we tried to get everolimus, but the insurance company or the pharmaceutical company was not interested in that. But Pfizer, who was the company that was in charge of sirolimus, gave us sirolimus for this patient. And then we did a phase 2 study and gave us sirolimus for that. So that's where that mTOR inhibitor came into play. And so we gave this child sirolimus, and this is what happened. So her disease got better. She was going to be put on. She really was going home on what we call palliative care because I didn't know what else to do for her. And this was an oral medicine that we could give her. And the other amazing thing that happened was this tumor is associated with something called Kasabach-Merritt phenomenon, where you have a profound decrease in your platelet count and a profound decrease in your fibrinogen. And that recovered in 4 weeks, and it stayed normal. So that was where sirolimus came from. And then we were very, very fortunate to get funded by the FDA for one of their orphan drug grants, and that's where this started. So it has not been approved. We're working again on approval. Initially, Pfizer was not interested in it, but now we have many more studies, and so we're working on getting it approved for certain vascular anomalies. There's been many reports of the use of sirolimus, and there's the indications that I list here. But the one important thing is we know what it doesn't work for. Again, going back to the heterogeneity of those diagnoses. But sirolimus is not enough, and it's so nice that that I'm going after the wonderful talk from MD Anderson, because this is a pathway that I actually had one of our plastic surgeons put in an article for me so I could use it to teach patients about this system. And this is the Rassopathy PIK3CA pathway. So it's a circle, but it's not meant to be a circle in and of itself. This sort of pathways go like this. And so now, because from that study, we went back to our scientists and we said, you have tissue. Most of this are somatic mutations. Please look at the tissue and check for somatic mutations. And so the first thing that they looked for was PIK3CA. And PIK3CA is a causative somatic mutation in all of these vascular anomalies. So we basically know now that this pathway is involved. Remember, all of these vascular anomalies look very different. And yes, we have alpelisib now. So we started with an AKT inhibitor. So we started down here with mTOR. We were able to get an AKT inhibitor, which was very effective for our patients, but unfortunately, it changed hands to another pharmaceutical company, and they're not interested in pursuing the vascular anomaly route. We were very lucky because PIK3CA came about, alpelisib came about by the same kind of power of one. There was a nephrologist in France who had a patient that came to him with that diagnosis, Cloves. He looked up Cloves on Google, and he found that it was a PIK3CA causative mutation. It was an overgrowth syndrome that was caused by PIK3CA. He looked up PIK3CA inhibitors. He found alpelisib, and he petitioned the French government to get this for his patients. So that became, I don't know if I call it a registry, but it became a managed access protocol. So a managed access protocol is where the drug company holds an IND. They give you a schema of how to use the drug, but that was opened in France. It was opened when I was in Boston, and it became FDA approved with that retrospective data, which is really unheard of. But it's a conditional approval because there's a prospective study with pros that's out there now. So we have to have the same findings in that study as the retrospective study. But it has opened up a world of things for us. So when I think about this and pathways, I think about why do patients with P10 get vascular anomalies? And P10 is part of that pathway. So because they have overactivation of AKT, overactivation of PIK3CA, and this pathway, you heard, is responsible for growth and differentiation. It's responsible for a cell being a fat cell, a cell being a blood vessel, a cell being a muscle cell. So if there's an issue, then P10 patients could have vascular anomalies. But why do they get different kinds of vascular anomalies? Why does one person have an AVM and another person has a combined lesion? Why are they in the areas that they're in? We still don't know about that. We have another side to this because some of our vascular anomalies are also over here. So the question is are there other we have a germline mutation in the P10, but are there other somatic mutations that we're missing? So we do panels on our patients that have the hamartomas, and we haven't found any of these other mutations, but we really need to investigate this more. And before we move into basically more therapeutic options for these patients, we also need the preclinical data to tell us how it's working. That I call it the mechanism. So how is this working? How is this working on our P10 models that have vascular anomalies? And there are scientists out there that are doing this modeling. So just to give you an idea of where we are, and this is with vascular anomalies and all the possible treatment options that are out there. And just to something to think about. So remember, I told you that these vascular anomalies are seen earlier. These don't go away like a cancer, right? They're congenital issues. So our goal is to reduce, not to eliminate. We can't use in these patients a maximum tolerated dose, and we're not even using that really necessarily in oncology patients. Our medicines potentially could be lifelong. So if we talk to Sid, and I was going to ask him, what happens if you stop the medicine? Does the neurological function that was improved then decrease? And that's what happens with our vascular anomalies. A lot of times if we stop the sirolimus, their vascular anomalies get worse. But I can try to use the lowest dose that gives us the best effect to try to decrease the side effects. And we have to remember that we're going to be treating children and adults. And I go to NCI every 3 months, and I always tell them, you're going to learn from our patients the medicines that we're using. And sure enough, I was there the last week, and we were talking about new information about the medicine propranolol. And we were also talking about alpelisib. I think they're starting to listen, because we have to work collaboratively. So we have a big consortium for vascular anomalies. We have 22 sites across the United States, and the lead site is here at CHOP. But we're also working with a consortium in Europe called VASCERN. And the other thing, so these are all the questions that I sort of went over already that I have for why in P10 that really need to be answered. But someone asked, what is it with a rare disease? How can you help? Well, awareness, because it has taken us a long time for NIH to realize what vascular anomalies are and who we are and the significance of the issue. And I think awareness of P10 and vascular anomalies and awareness of P10 because it's a rare disease and other things, it's important. We in the vascular anomaly world, just like you all are doing here, work with a lot of patient support groups. It is very important to lobby, to go to Capitol Hill, to lobby NIH, to really bring awareness. Because it's hard out there in the world. That my phase 2 sirolimus study, the FDA grant, cost $3 million to run. And it costs that much. The drug's very expensive. Alpelisib is very expensive, just on another side note. But it costs a lot to run a study because we want to make it safe for the patient. And so you need a lot of support in order to make that safe. And just other things to think about. So I'd like to thank mostly the patients and the families. And I wouldn't be where I was today if it weren't for the patient and the family support groups that I work with, because they've really driven me to want to change and want to improve the lives for these patients, and just my funding sources. And this institution here has been just so receptive to helping move this forward. Thank you.
Thank you so much, Dr. Adams. We just have a couple of online questions for you. And one of them is, are there any signs we should be looking out for to predict a vascular anomaly or to recognize a vascular anomaly?
So if vascular anomalies have the overgrowth component to it, and you saw that a lot of those patients are a bit tricky, then you will see one size, like one leg larger than the other, one arm larger than the other. If there's a cutaneous vascular stain, you're going to see that at birth. So if there is a capillary malformation, you'll see that at birth. If there is sort of a high flow lesion, you might have something called a capillary blush. But sometimes these are deeper, and sometimes they are not picked up until later. So if someone is having any pain and you check around it and there might be a lump or a bump, that would be a reason to be seen. Just the pain itself, though, would be a reason to be seen too if that didn't go away.
I'm going to follow up to that, and I'm going to combine two of the questions here. What do you recommend as the next step if there's concerns? Somebody was asking about, ultrasound or MRI. Somebody also asked if patients should be screened for vascular anomalies if they have a diagnosis of P10.
The screening is a good question. And I think with this group that we have, and when we come up with sort of the classification, and actually we're working, so we're taking what we're doing with that group and working with Dr. Eng, and I think we'll talk about those things. We use ultrasound a lot. So sometimes we definitely in the past we're using a lot of MRIs, but we can see a lot with ultrasound in the hands of a good person. And so I think I would always start with ultrasound. And if there's any question, an ultrasonographer in a hospital that doesn't see vascular anomalies might not know what they're looking at. I think that's what you have to be careful of, because sometimes these things can be called tumors and malignancies, and people can get very upset. But then they need to know where the vascular anomaly centers are. And probably if you have a P10 center, you're going to have a vascular anomaly center. So we have 22 sites that are in the consortium. So you have those larger groups, but there's also many, many smaller vascular anomaly centers that are out there. The only place that we are truly lacking in vascular anomaly centers is like the upper Midwest. So you have Seattle and Oregon, but you don't, and you have Denver, but you don't have anything else. Montana, there's someone in Utah too. And if there's any question, we can help them. So.
Hi. If a patient has P10, but there's no symptoms or pain or anything visible on their skin, do they still need to be evaluated for vascular anomaly?
Yeah, that's what we were talking about. We have not made, so we don't know if it's 30% that have vascular anomalies or really closer to 50%. So as far as that screening. And the screening that you would do probably would be a total body MRI, because you can't do like ultrasounds unless there's an area of interest. So to put someone through that, we really have to, I don't think that would be worthwhile yet. So if no one has any pain or any lumps or bumps or any skin changes, the likelihood is that they don't have a vascular anomaly. If any of those things change, then certainly you need to get that evaluated.
I think one question we've had a couple times in the chat now too is just about brain AVMs and screening brain MRIs.
Yeah, so I mean, we do see some CNS issues. Brain AVMs are not really that common. I mean, they're more developmental venous anomalies, which a lot of people will have I have a developmental venous anomaly. So, it's not as common. So, and I know that there are other reasons to screen for CNS issues, but I don't think vascular anomalies is one of them. That goes for the lung too.
Denise?
Yes.
Is the related question to screening is when to screen. Are these always present at birth, or can they develop later? And what's the latest they could develop if it's later? Because if they're present at birth, then you can just pick a time and just screen them, but because they're all going to be there. But if they can develop when you're 20 or 30, then you're not going to catch everything.
So Garrett, they're usually present, but you might not know it. So you can have a hamartoma that's present that grows. You can have a high flow lesion that's present and it grows. But they're usually always present at birth. But again, I'm not sure I'm ready without our consensus to say that we should screen everybody from head to toe, because some of them probably won't be picked up in the newborn period if they're very small. So most of them are picked up. So the the study that was done showed 5 or 6 years of age. We pick them up earlier now because they come to us earlier because we're the vascular, a specialty center. But we get people who show up later because people don't know. They call it a hemangioma. Hemangiomas go away. It's not going away. It's a capillary malformation. Sometimes those high flow hamartomas, they progress over time, and they might be just a little blush, which is a capillary malformation. And someone might not make that association of a patient has a large head and a capillary malformation. So they'll just say, oh, it's a capillary malformation, don't worry about it. So I think the majority of them are congenital, but they can progress over time. So they can be, I think it's unusual to have someone, except I had a patient that had a high flow hamartoma that was diagnosed when they were 26 years of age, but they had a lesion that was there, and people thought it was a lipoma. And so it wasn't until they came to a specialty. Someone finally did an ultrasound and it was high flow, and they went to a specialty center and had that picked up.
I have 3 questions. I noticed in one of your slides you had the category for lipomas. Is that considered a vascular anomaly?
Lipomas are different, but sometimes people can have lipomatous overgrowth, so fatty overgrowth, that gets misdiagnosed as a lipoma. So remember, that was going into charts retrospectively. So I bet you some of those lipomas were really true lipomas, but I think other of those were truly fatty overgrowth.
Got it. And something I just wanted to clarify, the difference in terms of a lipoma and a hamartoma is that we have blood flow, or can have blood flow in one, but maybe can you clarify that a little bit?
Yeah, so a hamartoma is a bunch of fibrous tissue when a pathologist looks at it under the microscope. It can have some fat, but it doesn't fully have fat throughout the whole lesion. And hamartomas can be without flow, so they're not necessarily, so hamartomas without high flow and hamartomas with high flow. The high flow hamartomas have a lot of extra tissue, but a lot of blood vessels. And so a lot of times people will either confuse them as a vascular tumor, or they'll say they're an AVM, and they're not. So they have a very different look radiologically and a very different look clinically. So I don't know if you remember the one of the on the neck. So that is more of a tumor. An AVM is going to have an area that's pulsating in one area, and all of your arteries around that AVM are going to be dilated.
Got it.
So, and again, if you don't do vascular anomalies all the time, you might
Know what you're
pick
looking
up
at.
on those subtleties.
Sure. And then my last question was, where is there a category that a ganglioma falls in with the categories you put up there?
No, because we wouldn't consider in the vascular
Acute
anomaly group.
category?
Yeah.
Got it. Okay. Thank you.
All right, I think we're gonna have to pause there with questions, sorry. Thank you so much, Dr. Adams. Two quick announcements before lunch. Want to make sure everybody had time to eat. So the first is that we'll have at 1 o'clock, Dr. Shavison will be in here for our breakout session. And then we'll put up the revised schedule during the lunch break, just so you can take a look at that, since there have been a couple of changes. The second is just, I wanted to give a quick thank you to Jamie and Allie up at front. They've really been the masterminds, along with Chris and Anthony, in planning this whole conference. Behind the scenes, a lot of work has gone into this. And if you ever call our clinic, you've also probably talked to Allie and know how fantastic she is in helping us to get all of these visits coordinated between specialists. So quick thank you to them before we break for lunch. Thank you.